Hello and welcome to the Spine Nerd Podcast. My name is Dr. Brian Joves.
And my name is Dr. Nicolas Karvelas.
And thank you all for joining us. We really do appreciate you giving us your attention, and hopefully you're learning something and providing value to you. Thank you for sharing this with your co-residents, med students, maybe fellow partners in your practice. It means the world to us that we're able to help in your education and maybe entertain you a little bit. I don't think we're very entertaining though, on your commute to work or on your walk this morning. We have been going through a Back to Basics series for the entirety of 2021. And as we get to this fourth quarter of the year, we actually just wanted to kind of come over or go over some studies that have been really interesting to us that we haven't had a place for in that Back to Basics series. And so one of the things that Dr. Karvelas has really wanted to cover for probably about 2 years now are sodium channels. And so strap in for some awesome basic science, guys, because we are here for it. Dr. K, take us away.
Yeah, and so today we'll be discussing voltage-gated sodium channels and specifically medications that can selectively target certain subtypes of those voltage-gated sodium channels. And, you know, obviously in medicine and obviously in the field of pain medicine, we're constantly looking to optimize our treatment options for our patients. And, you know, medications from a medication standpoint, that's always somewhat of a struggle because as we know, a lot of our non-opioid medications, although can be effective in certain situations, are not without their specific side effects. You know, when we think about gabapentin, pregabalin, duloxetine, topiramate, you know, or NSAIDs, all of those medications, like I said, although they have some benefit, they are definitely not without risk, especially when you start adding certain patient comorbidities. And obviously, as we've been over and over again, opioids definitely come with their own, you know, baggage in terms of all the different risk and potential negative long-term effects. And so, with selective voltage-gating sodium channel modulators, this is a relatively new frontier from a medication standpoint, with the goal of finding molecules that can modulate sodium channels in a way to provide significant analgesia, but because they're targeting specific voltage-gating sodium channels, minimizing those potential side effects. Because as we know, our non-selective sodium channel blockers definitely do come with a fair amount of potential side effects. So starting with some basics on voltage-gating sodium channels. So to the best of our knowledge, there are 10 different voltage-gating sodium channel subtypes, and voltage-gating sodium channel subtype 1.7, 1.8, and 1.9 are the primary voltage-gating sodium channels in the peripheral nervous system and the DRG. And obviously, as you can imagine, that has implications from a pain pathway and ultimately from an analgesia perspective.
Side note, DRG, dorsal root ganglion.
Yes. And, you know, the fact that there are different voltage-gated sodium channel subtypes with a variable prevalence in different tissues throughout the human body is really the basis and the driving force behind this concept of targeting specific voltage-gating sodium channel subtypes for the treatment of pain. And when we think about those subtypes 1.7, 1.8, and 1.9, which I'll probably refer to them as 1.7, 1.8, 1.9, so you don't have to hear me keep saying voltage-gating sodium channel over and over again. But for those subtypes, it's really, you know, over the course of time and research and evaluating clinical phenotypes, that we found that certain mutations in these genes have been linked to certain disease processes that are characterized by significant alterations in pain processing. So varying from chronic conditions with more severe pain, or conditions where you actually have a insensitivity to pain. So just as a couple quick examples that we may have heard of clinically. So erythromyalgia is actually a gain of function in terms of that 1.7 subtype. But when you have a loss of function of the 1.7 subtype, that is called congenital indifference to pain. And if you've heard of Ripley's Believe It or Not, there's a kind of a famous poster with a gentleman who has needles kind of throughout his entire body poked through him, and that individual had the 1.7 mutation where he had the congenital indifference to pain, and that's why he was able to do that for a living. So, importantly, depending upon the specific pain condition, specific voltage gain sodium channel subtypes may be more optimal options to consider for targeting. So for example, because I bring up that point because I think it's important that we understand that these different subtypes, for the different types of pain that we know that we are working with our patients, whether that be predominantly neuropathic or predominantly nociceptive or inflammatory, that does ultimately matter in terms of which subtype we end up targeting. And so, as I said, for an example, so voltage gain sodium channel subtype 1.9 may be an excellent target for inflammatory type of pain, but play a more limited role in neuropathic pain. The other thing I wanted to bring up before we dive in a little bit deeper into a specific journal article here is that the patient's comorbidities really come into play as well. And just as one example of this is that if an individual has cancer, there's actually research showing that targeting specific subtypes of the sodium channels can actually have a positive impact on cancer progression. And that concept really came out of some initial observational studies that noticed that for individuals that were on sodium channel blockers, whether it be for seizure prevention, that they tended to have a lower incidence and decreased severity of cancer. And this led to studies including looking at topiramate for solid tumors, including gynecologic tumors, and showing some potential benefit there. And one of the theories in terms of how sodium channel modulation has a positive impact on cancer is that the cancer cells utilize sodium channel pumps, and specifically a sodium and proton antiporter to acidify the environment, which then obviously allows helps that cancer cell metastasize or break down tissue and the progression of the cancer. And so by blocking the sodium channel, you actually minimize that ability of the tumor cell to acidify the environment and for the tumor to grow. So
before we get a little bit farther into this and specifically into the journal article, we've kind of taken a roundabout way of talking about how sodium channels are massively important in lots of different things, from inflammatory pain to neuropathic pain to not feeling pain or having an abundance of pain that is felt, and then to cancer. So can we take maybe a step back and give a little bit broader understanding or reference to voltage-gated sodium channels in physiology? Like so obviously there are subtypes specific for pain that are helpful that we're going to get to and talk about some of the modulators to affect. But if for somebody who maybe hasn't heard or hasn't thought about voltage-gated sodium channels since basic physiology, and this hasn't been a part of their normal thought process, can you give us a little bit more understanding and clarity on kind of where these fall in our physiology?
Yeah, and I think that's a good point to emphasize, because when we think about voltage-gain sodium channels, we predominantly think about the conduction of an action potential down a neuron. And of course, that's an incredibly essential process in our body that the voltage-gated sodium channels serve to accomplish for us. And so, the ability to sense changes in voltage due to different stimuli, and then leading to the development of an action potential, which is conducted down a neuron and obviously accomplishes so many essential functions in our body. Now, the other thing I would emphasize, though, is that the more and more we learn about these voltage gain sodium channels is that they're not limited to just neurons. They actually are present in non-neuronal cells, and they actually have functions including the release of insulin from the pancreas, and they're also in intracardiac cells in the heart, and that's a very important thing to keep in mind, especially when we're talking about the 1.8 subtype that we're going to address today in the journal article, because what we found is that modulation of those 1.8 subtypes in the non-neuronal cells in the heart can actually lead to some PR interval prolongation and potentially even arrhythmias and heart block. And so bottom line is it's important to be aware that, yes, although we're the primary function of these voltage gain sodium channels is the conductance of an action potential down a neuron, that they are present in other non-neuronal cells throughout the body.
Thank you. Yeah, I think that helps to add a little bit more insight into where these fall into the overall physiology for those of us that have forgotten some of our sodium channels over time.
Yeah. So a couple other things here as we head into the article itself. So I know I mentioned the 1.7, 1.8, and 1.9 subtype and the fact that they play critical roles in pain signaling. There is data to support that 1.3 also does play a role in pain processing. For the sake of this journal article, we're actually going to be focusing on 1.8 because it was the molecule or a molecule modulating 1.8 that was studied in this specific research paper. So 1.8 is a sensory neuron-specific channel with a preferential expression in the dorsal root ganglion and trigeminal ganglion neurons. And obviously, as we've brought up before, the high prevalence of 1.8 in the dorsal root ganglion obviously makes it a attractive target for pain modulation, because we know how critical the dorsal root ganglion is for the transmission of the pain signal and the modulation of that pain signal. Now, so the going back to the concept that we brought up before, where you had the gain of function mutation in 1.7 that led to erythromelalgia, and you had the loss of function, which led to that congenital indifference to pain. Same thing with 1.8. When we see a gain of function 1.8 mutation, what we see is that we actually can develop some small fiber neuropathy, chronic pain disease processes. And so 1.8 does seem to play a significant role in neuropathic type of pain, and like I said, sometimes clinically manifests as this small fiber neuropathy condition. So some characteristics of 1.8 is that the receptor itself, the channel itself recovers relatively quickly from inactivation, which highlights its involvement in repetitive firing and neuronal excitability. And consequently, we can think about that when we think about the mechanisms that lead to central and peripheral sensitization in terms of that repetitive firing and ultimately the sensitization of the neuron. So again, providing us evidence that 1.8 most likely plays a significant role in central and peripheral sensitization. The current research at this time does support the theory that 1.8 may have a potential, be a very good potential target for the treatment of pain, including pain for which the nociceptor hyperexcitability plays a dominant role. And so that just goes back to the concept that, yes, this umbrella of selective sodium channel modulation has a similarity in the sense that we're targeting these voltage gain sodium channels, but the specific subtype or the specific clinical presentation of the patient does ultimately matter in terms of what voltage gain sodium channel we are targeting. So
yeah, and so I know at this point you guys are probably thinking, oh, you guys really talk a lot about central and peripheral sensitization. And it's true, we do, because we treat chronic pain. And I think that, as we've explained multiple times, central and peripheral sensitization are such a big component of trying to understand and then therefore create modalities to be able to address patients who are living with chronic pain. And so, there are a lot of different factors and a lot of different things that play into that. This is just another one that has research supporting it. And now that we're trying to develop modalities to address in terms of all of the gigantic cascade that is involved in the central and peripheral processes.
Yes. So the specific molecule that this article looked at was a molecule called VX-150. Essentially what this is it's an orally bioavailable prodrug, which is rapidly converted to its active entity and is obviously a highly selective inhibitor of voltage gating sodium channel 1.8, about 400 fold greater affinity for 1.8 compared to the other 10 subtypes that we had brought up for the voltage gating sodium channels. So this study was published by Dr. Hima and colleagues and published in Pain Medicine this year in 2021. It was titled a phase 1 randomized double-blind placebo-controlled crossover study to evaluate the pharmacodynamic effects of VX-150, a highly selective voltage gating sodium channel 1.8 inhibitor in healthy adult males. The reason that they, just as a side note, the reason they chose males was because specifically for this, early on phase 1 trial, looking at multiple things in terms of a battery of different pain tests, as well as obviously the pharmacodynamics, they acknowledged that throughout the menstrual cycle, a woman's pain integration may change, and so they just wanted to keep as simple as possible and limit the number of variables, understanding that obviously in the near future they're going to be making it more clinically applicable in terms of a broader patient population. So just in case anyone was wondering for the question of why it was males, that was the reason behind it. Now, moving on to the methods of the study. So this was conducted at the Center of Human Drug Research in the Netherlands. As I mentioned, it was a phase 1 randomized double-blind placebo two-way crossover study. So essentially with those 20 male subjects enrolled, there was a 1-to-1 ratio for the two different treatment sequences. And so the first treatment sequence, the individual got 1 dose of the VX-150, specifically at 1,250 milligrams. And then after that 1 dose, there was a 7-day washout, and then they got 1 dose of placebo. And obviously in the other arm, they got the dose of placebo, the 7-day washout, and then the dose of VX-150. And immediately after the dose of the medication, obviously there was a battery of validated pain measurements or pain tests performed. And so the testing was performed twice before the dosing of the placebo and or the VX-150, and then after it was performed twice before the dosing of the medication, the testing was again performed at 1, 2, 4, 7, and 10 hours after dosing, obviously to get a sense of when that peak effect of the medication was occurring. The validated pain tests they utilized were the electrical stare pain test, pressure pain test, cold pressure pain test, and heat pain test. The measurements that they included the threshold where the individual first sensed pain, and then also the pain tolerance threshold. So essentially the pain detection threshold and then the pain tolerance threshold were the two major outcome measures. And so in terms of the results of the study, essentially what they found that significant effects were observed for the cold pressor test and the heat pain test. And although for the other validated pain tests, there was trends in terms of or in terms of statistically significant outcomes, it was really the cold pressor test and the heat pain test that had the most significant values. And so just to give us a sense of what those outcomes ultimately were. So with the cold pressor test, so just as a reminder of that, what that test is, the subjects hold their hand in 1 degree Celsius water, and then you measure the time to when they first detect pain, and then the point at which they're no longer able to tolerate, and that's measured in seconds. And so the largest treatment effect was at 4 hours for the cold pressure test, and obviously 4 hours after dosing, and it was statistically significant at 2, 4, 7, and 10 hours as well. At 4 hours, where after the dose, which I mentioned was when there was the greatest effect, the subjects who took placebo reached their pain tolerance threshold at 20 seconds on average, compared to the subjects who took the VX150, who reached their pain tolerance threshold at about 49 seconds on average. So 20 seconds versus 49 seconds, obviously a fairly drastic difference there. For the heat pain tests, the subjects who took placebo had consistently lower scores, or essentially less tolerance of the heat compared to the subjects who were treated with the VX150. The most statistically significant time points were 2 hours and 10 hours after the dose. So for example, at 10 hours, the pain detection threshold was essentially at 43.16 degrees Celsius in the placebo group versus 44.07 degrees Celsius in the VX150 group. And like I said, for the other pain battery test, although there were some trends, it wasn't statistically significant as it was in the cold pressor and heat pain test. Obviously, safety is a huge thing. So overall, the VX150 was well tolerated with no severe adverse effects. The adverse events that were reported were evaluated carefully and determined to be mild to moderate. The incidence of adverse effects in the subjects receiving VX150 were similar to placebo, and no subjects ended up discontinuing the test due to adverse events. The most common adverse event was headache, which was about 10% in both groups. So essentially, there were no clinically meaningful concerning changes or trends in labs. So the things that were monitored during the trial included labs, including a CMP, CBC, coagulation labs, and urinalysis. They also monitored vital signs and an EKG. Obviously, in my mind, the EKG would be one of the most important things to be monitoring, and specifically that PR interval that I had brought up, because as I mentioned, these voltage gain sodium channels, although predominantly present in the neurons, obviously, as we've emphasized, they are present in non-neuronal cells, including within the heart, and have been demonstrated to impact the PR interval. And so specifically with 1.8, that's something that we want to be very cognizant of as the trials continue to progress. So ultimately, the author's conclusion from this study was that this study was performed to evaluate the analgesic potential of a single dose of VX150 in the setting of a panel of various validated pain tests. And overall, VX150 demonstrated an analgesic response up to 10 hours for a subset of pain tests, as we mentioned, that cold pressor and heat pain tests specifically, without any significant adverse effects that they saw in this specific trial. And this supports the use of selective voltage gain sodium channel modulators, and obviously in this case specifically 1.8 modulators as a potential treatment option for pain. So one thing that they, just in terms of the other validated pain tests that they saw trends but not statistically significant variables, they hypothesized that this was more so due to their relatively small power of the study, 10 subjects in each arm, and that there was actually quite a bit of variability even within that small group of subjects. And so the relatively small power of the study and the variability within the results was their hypothesis of why there was trends but not statistically significant outcomes for those other pain battery tests.
Yeah. So, I mean, obviously this is early in terms of development, and this is not something that probably is going to be clinically relevant for anybody who might be listening in anything that resembles the near future. But why is this something that's so interesting for you? I mean, this has been something that I think, as long as I remember, you've we wanted to talk more about sodium channels.
No, I think it goes back to, and sorry, just to wrap up real quickly, because yeah, to your point, this is obviously, I think the purpose behind this test is obviously to look at the the pharmacodynamics of the medication, and finding really when it's at its peak effect in the serum. Obviously making sure it's tolerated without significant side effects. But there have been some studies looking at VX-150 more so in a little bit more of a clinical scenario. So I just wanted to mention those ones as well. So these were kind of proof of concept trials that were done relatively recently for VX-150 as well. And so VX-150 demonstrated analgesic benefit for acute pain in patients status post foot surgery. And they also noticed improved pain scores for individuals with chronic pain due to a diagnosis of small fiber neuropathy, which obviously is a potential target because, as we brought up, that 1.8 subtype seems to play a significant role in terms of that central and peripheral sensitization, and to be located in certain areas of the body that would make sense in terms of that small fiber neuropathy. And the other thing I'll mention as well is that there are some studies that compared VX-150 to Pregabalin or Lyrica, and then also fentanyl at 3 micrograms per kg. And the VX-150 actually outperformed Pregabalin and fentanyl in terms of pain scores, which obviously those are two medications that we use quite obviously, especially in terms of Pregabalin, we use quite commonly, especially to treat neuropathic pain. But to go back to your question of why this is something that I do kind of keep an eye out for in terms of different studies that manifest themselves in the literature. I think it first off, it goes back to the fact that we're still working to optimize our toolbox from a medication standpoint, because although we definitely have treatment options for patients, there are quite a bit of limitations in terms of patient tolerance, side effects, adverse events. We really don't have that perfect medication, and not that we'll ever necessarily find that, but continuing to try to find the medications that do have more and more analgesic potential with less and less potential side effects. And I think so that's with the selective component of this, being able to say, okay, we're going to specifically target this subtype of the sodium channel. Obviously that theoretically should lead to a scenario where we have fewer and fewer side effects for the patient. So I think just that in and of itself, decreasing adverse effects, decreasing side effects, I think is something that's very attractive to me. The other, I think, interesting component of this is, obviously we deal with a fair amount of cancer-associated pain. And so that's always, once I started seeing the studies from the oncology literature, that idea, and I do that to some degree if I have a patient who comes in who has cancer-associated pain, especially if it's a neuropathic cancer-associated pain, and I think that topiramate might be an option for that patient. I will obviously message the oncologist, the treating oncologist, and say, hey, look, I'm considering this treatment option. Do you think that's reasonable? And it won't interfere with any of the other treatments that the patient is getting. As long as the answer is yes, then I'll initiate that medication and I make sure to emphasize, in my note, that we're using topiramate for the primary purpose of treating the pain, especially the neuropathic pain, with the potential positive impact on cancer progression.
Nice. Well, thank you for that rundown. I hope you guys enjoyed that nice walk through memory lane of physiology, and possibly, look back and then look forward to something that would be hopefully available to help treat our patients in the not too distant future. If you guys made it this far, send Dr. Karvelas a message and tell him how much you love when he dives deep into basic sciences. It really makes him happy. He'll even smile if you do it. possibly.
Yeah.
Otherwise, thank you guys for listening. Stay tuned for those legal disclaimers. And if anybody out there is interested in helping us with audio and video editing, please reach out. We do not know how to do this. We see patients for our day jobs, and this is a side project that has reached more people than we ever could have dreamed, and we appreciate that, but would also really like some help in that area if someone is so inclined. So closing thoughts?
That's it. Thank you.
All right, go Giants, go Niners. Hopefully by the time we talk to you guys next, we'll have better news than we had this past weekend. Have a good one.